So I now call upon our next speaker, co-instructor, Dr. SHARON DSOUZA. She's a consultant cornea and refractive services with us, Narayan Italia. She'll be speaking on the role of epithelial mapping, and maybe after this we'll open the floor to certain questions. Yeah, over to you, Dr. SHARON.
Good morning, everyone. It's an absolute pleasure and honor to be here speaking on this topic. Thank you, Dr. Garrick, for including me. So I think we've had some great talks regarding various diagnostics, and this is something which is part of the present and definitely would be part of the future of how we look at the eye. Of course, there's a long way to go. It's not that easily available to us yet, but the idea is to just bring about a thought and trigger some thought process on what we are seeing and what we are not seeing. So why is the corneal epithelium important in our clinical practice? So if you remember all our regular topographies, we know that we get a refractive map, we get a pachymetry map. But as Dr. Garrick was saying, the epithelium is a beautiful structure which by nature tends to regularize the cornea, fill in gaps if there are, fill in depressions if there are, cover off any irregularities that may be underlying, and that is inherent to the nature of the cornea. And there are very few diagnostic devices available to us which would separate out the epithelium, the stroma, and the elevations. And no financial interest in any of this, but this is one of the devices available to us, where if you see on the left side, we do have the right side, the corneal thickness available, and below that we have the epithelial thickness. And I'll be coming to what it means. So epithelium can act as either as a masquerader, or it may disguise something underlying. So if you see on the right side, that map, that irregularity, that is from the surface of the cornea, and that is what we normally measure. Whereas if we remove the epithelium, and that is the map on the left, and that shows the stromal change, and that is what we ideally should be measuring if we are trying to look at a weakness in the cornea, whether it be an ectasia or a fitness for a refractive surgery, because that's where many of these devices are used. So the true picture very often comes from looking or separating out these structures. And even though there have been studies around the world where they've done it manually, physically removed it and re-imaged the eye, we now have devices which can do this by various extrapolation or algorithms. So our current day topographers would image the surface, whereas over time we would like to have more and more devices looking at separating out the epithelium and stroma to really study the cornea. Now, why is this important? Why are we harping on this so much? So let's see some case examples to understand the importance of the corneal epithelium further. This was a young lady who was interested in refractive surgery, and even though we know that it's more or less normal, there's that little bit of irregularity, that inferior superior asymmetry that we are seeing on the topography on its sagittal curvature, which puts in a little hesitancy on whether we should go ahead with a refractive surgery for this patient. Everything else seems pristine, everything is fine, the pachymetry is good, so otherwise we shouldn't have an issue. But especially when we're starting out, there's a little fear of whether 10 years down the line or sometime down the line this patient's going to have a problem. As I said, everything looks great even on the Bell-Ambrosio display. So is this patient then fit for a corneal-based refractive surgery, and what additional information would be helpful? So just to reiterate that a little further, this is a different case where we again are seeing that inferior superior asymmetry, that that inferior steepening, but when we look at it subdivided further, we can understand that that epithelial irregularity is causing that little slight change in the curvature and giving us a false image. So this is what we are trying to look at when we look at the epithelial mapping, where although the pachymetry seems more or less regular, there's even pachymetry all through, the epithelium has got an irregularity about 5 microns across. And is 5 microns that much? That it's causing so much of dioptric change on the keratometry, and actually, surprisingly, it can. So it's mainly epithelial changes and no stromal elevation. So that's where we are a little more confident in going ahead with a procedure for this patient. Even in keratoconus, you could have the similar, benefits where we're sometimes wondering, we come back with a patient who may or may not have had a cross-linking, but looks like he has a progression. And we're not sure why it's looking like there's a progression, the patient has had a surgery or not had a surgery, and we wanted to clarify what that is. So it could actually be that there is an epithelial thickening or an epithelial irregularity which is actually contributing to this pseudo progression that we see. And once we know that there's no significant stromal elevation, we would know not to rush into a second procedure if required. Similarly, you can the applications are pretty much endless, and even in our routine cataract surgeries, when we're planning premium IOLs, we've been trained to look for irregularities in cornea which may contribute to visual disturbances in the patient post-operative. And if there's a more of irregularity, we'd probably want to avoid this. So in the interest of time, I'm just going to go through this a little further, but the highlight of it is that epithelium, even though it's just 50 microns, just 5 microns of change, 10 microns of change, it can actually contribute significantly to the aberrations as well. Even though it sounds so whimsical, it can. And if you take a step back, or the corollary to that is that sometimes after surgery, if you're not sure and the patient is unhappy, it may be just a surface irregularity, which, some epithelial change, which is making the patient have some visual disturbances, night glare, and treating that could help the patient, improve and be happier again. So why would abnormal epithelium affect the visual outcome post-cataract surgery? So if there's an irregular surface to start off, then it may affect how we measure the keratometry, the biometry, and thereby, may result in some sort of a surprise in terms of our refraction. Even if your refraction biometry is spot on, you can still have some visual disturbances, because as I was saying, you can have an aberrations induced by the epithelium itself. So again, how does it, so if we are doing a premium IOL, how does it help us? Consider that if there is irregularity, and this is a given, everyone goes by it, so if there's a lot of irregularity on the cornea, you're not going to maybe be a little more cautious on planning a premium IOL, but this is taking it one step further and looking at the epithelium, and if you feel that it is something which is treatable, you could probably treat that before you plan a premium IOL. So caution, because that would then contribute to your astigmatism and how it impacts the surgical outcomes. So why does this, why are we looking at epithelium so closely? It is a sort of a marker for what is underneath. So it's surrounded by the nerves, the cells, the molecular factors, and over time we've realized that even though it is a small subset of patients, there are still those who need to be looked at, because otherwise they're going to come back and bite you forever in practice, and that really becomes very, very difficult. So of course, a lot of personal experience on this, and we've realized that it can influence the visual acuity and visual quality, and even as a refractive cataract surgeon over time, it does matter. So MS39 is just one such device, and it's an OCT-based device, which is why it can differentiate between the epithelium and stroma, and it looks at both the curvature and the refractive powers and the elevations. And of course, this was a paper which was published by a group which looked at the Bowman's layer separately to try and get these outcomes themselves. Thank you very much for a patient list.
Hi, wonderful talks. I could attend the last two, but something I'm surely have gained. What I want to ask is that we are also trying to look at epithelium. I don't have the MS39, but I do have the AIOC2022. So I wanted to know how true does it show the epithelium, as in can I rely on it to diagnose certain cases of keratoconus, obviously by correlating with the pentacam maps. And another thing is, how much importance can I give it in a dry eye patient? Do I wait it out, or do I say that my measurements are true if there is a slight irregularity in the epithelium?
Right, great question, and something which is very intuitive actually. So the challenge there is if it's a regular OCT, which we see the shine plug or that image, the raster image. If you are measuring the epithelium from there is no guarantee that at each visit you're going to do it from the exact same place as previously. Plus, it's very difficult to have measured all the different quadrants or points which a map like this would show. So it's a little more challenging, and there may be room for error there. So if you're following up the patient, if that is your idea, that over time you look at it and if there was epithelial thinning or thickening, you can follow it up. It's very difficult to do because there's no way to guarantee you're at the same place again, even if you put your marker or your quadrant into it. So that is a challenge with it. Of course, for one-off, you're looking at epithelial hypertrophy or a scar there. That is excellent. I mean, they're very, very good. No harm. We rely on it completely. If you have to plan a PTK for such a scar or something like that, that's great. But in terms of for the purpose of trying to see if this patient's epithelium is going to regularize over time, it may be very difficult. And to come into your next point of question, that if we can treat it or how long to wait, again, following it up based only on that kind of OCT may be difficult. But yes, clinical judgment there becomes very essential, because many of this, if it's a real hypertrophy, you may see, or it's a post-surgical, you may see it and try to treat it by using your lubricant or anti-inflammatory, whatever, and look for other signs like ocular surface inflammation. There's a lot of allergy, dry eye. Any of that would give you a sort of hint to try and follow up. Whether you'll go ahead and do a surgery would depend on a lot of other factors and not only on this completely. So, you're looking at so many different factors and how severe it is. But yes, if you have one-off map of this, you'll weigh a lot of other factors and then try to maybe get the same map and compare that, just like how we do with topo. You need to compare.
When you say that I can't replicate it, does MS39 help?
So
you do
because
that?
it gives you a map, already a formed map,
Okay.
where it's measuring at the same areas and giving you a map is just easier.
So if in the first case, you skipped that case. It was very interesting to see where you showed that there were some irregularities, nothing showing up on the Bellin map. And then what would you decide depending on the epithelium? How would you decide whether you want to go ahead with LASIK or not? So
if the epithelium, if it's purely an epithelial irregularity and the stroma looks fine, then you
that
can
is with
still
the MS39.
With that.
Okay.
With that. Otherwise, it's how we routinely do in our clinical practice. You will, depending on how bad that irregularity is, or if there are other features, you will wait and watch or plan a PRK or a surface ablation. So your judgment calls remain the same. This makes life a little easier.
Thank you so much. Lovely talk.
Yeah. Any other questions? So I would like to thank everyone who have attended the session, and that too on the first day morning. We do understand it's a little bit challenging because everyone's traveled. And I would like to thank the AIOS also for giving our group this opportunity for the Young Masters course. I would now